Thank you very much. Kevin Chen is one of our hand therapists, and he's going to talk to us about the hand therapy considerations in compressive neuropathies. Please go ahead when you're ready.
Can you guys hear me?
Yes.
Great. Thank you, Dr. Paxima, for the introduction. Again, my name is Kevin Chen. I'm an occupational therapist and CHT at NYU Langone Orthopedic Center. And again, I'll be discussing the role of hand therapy in the management of compressive neuropathy in both the pre- and post-operative patient. So the goals for this lecture is, of course, to explain the evaluation process of hand therapy and to describe the common methods and techniques hand therapists utilize for this population. So let's jump right in. So after the doctor diagnoses the patient and the patient arrives at hand therapy with a referral, we'll go through our own evaluation to assess the patient's current level of capability, which will govern the interventions that we will implement. Strength is, of course, assessed by the Jamar dynamometry and manual muscle testing. Patients are also screened for range of motion deficits, which will be formally measured via goniometry if necessary. Sensation is assessed via two-point discrimination and Sims-Weinstein monofilament testing. We will also perform a battery of provocative tests and maneuvers. One such maneuver is the upper limb nerve tension test as described by physiotherapist David Butler. And each test will obviously be different depending on which nerve you are assessing. And we'll be discussing this in further detail later. For the post-operative patient, we will, of course, assess the condition of their surgical site and their scar. As therapists, it is, of course, our duty to monitor post-operative wounds for signs of infection and report this back to the referring physician for further evaluation and possible treatment. And lastly, we evaluate the patient's context and environment for areas of opportunity that we can address to set the patient up for success. So let's talk specifics about the median nerve. So again, we will perform a battery of provocative tests such as Phelan's, Snell's, and Durkin's to best understand how the patient is presenting. One of which is the upper limb nerve tension test, and these 6 pictures demonstrate the tension test maneuver for the median nerve. Although you might not have a partner beside you to passively perform this test, I invite you to attempt this series actively while you're at the comfort of your own home. Beginning with position 0 at the top left-hand corner, the subject is passively placed into each position in sequential order. And at each position, the subject is asked if their symptoms are reproduced. Once the provocative position is identified, the test is completed, and these findings dictate and govern our intervention process, where we assign the appropriate nerve glide. Displayed are some examples of glides that we might provide to a patient. Again, the prescribed glide is determined by the findings from the upper limb nerve tension test that we previously discussed. It is important to note that the effectiveness of nerve gliding in general remains to be controversial. Some studies point that the biomechanical behavior of peripheral nerves is not very well understood, which calls for further investigation and research. Despite the lack of statistically significant evidence, nerve gliding can be effective anecdotally, and thus is a helpful tool in the hand therapy toolbox. Custom splinting is also a valuable tool in the realm of hand therapy for the treatment of many diagnoses, including the conservative treatment of mild carpal tunnel syndrome. Pictured here is a volar wrist cock-up splint, which can be worn both full-time or at night to maintain the wrist in a neutral position. By maintaining the wrist in neutral, the risk to inadvertently rest in a provocative position, in essence, the Phelan's or the reverse Phelan's positions, is eliminated. However, in the instance where the compression of the median nerve is a result of lumbrical migration into the carpal tunnel, the traditional wrist support splint will need to be modified. Displayed here is a wrist cock-up with the MPs blocked into slight extension, preventing the MPs from achieving full flexion. Depending on the severity of the case, the MPs may need to be positioned further into extension than what is pictured here. For the postoperative patient, one immediate concern is scarring. While some patients are blessed with genetics that allow them to heal quickly and easily, some might not be so fortunate. As a scar develops, it can become hypertrophic, sensitive, and painful to touch, and the developing scar tissue could also entrap the very nerve that was just decompressed. Strategies in which we as hand therapists utilize to address scarring include manual scar massage and using putty elastomer and silicone gel sheets. Some studies point that after a wound has healed, moisture evaporates more rapidly through scar tissue and can take up to a year before it returns to pre-wound levels. Through the use of hydrating creams and silicone gel sheets, the ability to retain hydration is restored, preventing excessive scar formation. For the sensitive scar, we expose the hypersensitive region with varying textures, building tolerance gradually so that the affected area becomes tolerant to normal daily stimuli. Every patient that comes in with compressive neuropathy is very likely to complain of muscular weakness and how it has detrimentally impacted their lives. It is our responsibility to address these concerns, and to best set our patients up for success, exercises should respect the order of motoric return following a nerve lesion. Strengthening exercises can be as straightforward as dumbbell curls to creative uses of therapy. Depending on the patient's capability, an exercise can be performed with gravity eliminated, or it can be complex with varying elements to hit multiple muscle groups. Displayed here are some examples of strengthening exercises that we employ in hand therapy, especially for muscles affected by median neuropathy. While knowing and understanding the patient is critical in all stages of care, I find that it is especially important here in the strengthening phase. Is the patient the type to be overzealous with their strengthening and do 5 sets of 50? Or perhaps they're the anxious type and benefits from encouragement and positive feedback instead. Either way, knowing and understanding the audience is key to success. So now we'll move on to the ulnar nerve. Again, we would evaluate the patient's status at initial eval with a battery of provocative tests. And again, included in our evaluation is the ulnar nerve tension test. Again, although the test requires a clinician to perform this test passively on the subject, I invite you to perform this test on yourself actively. Once again, with the results from our tension test, we will prescribe the appropriate nerve glide. The concept of nerve gliding dictates that while the subject places tension on the nerve distally, the subject side bends their neck to the ipsilateral side, therefore decreasing tension proximally, which you can see demonstrated in all of these images. With regards to splinting, especially for the ulnar nerve that subluxes, we would provide an elbow extension splint. Shown here is a prefabricated elbow extension splint that we commonly use. By maintaining the elbow in a slightly extended position and preventing symptom-provoking positions, the risk of ulnar nerve compression at the elbow is decreased. In the event of a severe ulnar nerve lesion, an ulnar claw can be observed. In this scenario, the ulnar nerve innervated intrinsics are unable to extend the IP joints of the finger. The MPs of the ring and small finger are positioned in hyperextension because of the imbalance between the properly innervated EDC and also the weakened ulnarly innervated lumbricals. Depending on the level of the lesion, the ulnar heads of the FDP may also be affected. Regardless of the lesion, the ulnar claw deformity results in a significantly non-functional hand. What we can do as hand therapists is to fabricate what is known as an anti-claw splint, which positions the patient's ulnar 2 MPs into a flexed position, correcting the hyperextended deformity and giving the patient an opportunity to function in their daily life. With ulnar neuropathy, exercises can be tailored to strengthen the intrinsics of the hand and, of course, progressing to power grasping. Lastly, we have the radial nerve. Again, we assess for upper limb nerve tension testing and subsequently assign the appropriate nerve glide. Now, this is especially useful for a patient with radial tunnel syndrome. And as we've heard earlier, the radial nerve is vulnerable in many different areas at the so-called radial tunnel, which results in motoric dysfunction as well as a significantly localized pain at the lateral elbow. Nerve glides and wrist extensor stretches may be helpful in treating a patient diagnosed with radial tunnel syndrome, but much less helpful with a patient with radial palsy. In the event of a high-level radial nerve neuropraxia, a patient might experience the inability to actively supinate the forearm, extend the wrist, nor the ability to extend the MPs of the hand. This phenomenon is commonly known as wrist drop. This position is entirely non-functional because as we go about our day, we reach and we grasp with a tenodesis grip, where we grip and grasp while having our wrist in the extended position. In mild cases of this, where it is expected that the nerve function will return quickly, splinting may be an option for this patient. Using and revising the molar wrist cock-up splint we had previously mentioned, we can position the patient in with the wrist in a much more extended position, therefore decreasing the tension on the radial nerve as it returns. However, for a much more complicated case of wrist drop, a more imaginative splint is required to maximize the patient's function. In that scenario, we would fabricate a dynamic radial nerve palsy splint. On the left, you'll find two dynamic splints that allow for active digit flexion, which is, of course, unaffected by radial nerve neuropathies. With the use of the outrigger, it passively brings the patient's MPs into extension, allowing for the patient to actively release a grasped object. You may notice that the two splints are dissimilar in that the top one does not include a wrist component, which is included in the lower splint. That is because the lower splint is fabricated for a patient with a higher level nerve compression, where active wrist extension is absent in addition to the absent digit extension. Here you'll see a dorsal and volar view of the low-profile radial nerve palsy splint, which serves as an alternative option for patients who would prefer not to have their splint include an outrigger. And of course, it offers the same purpose as the previously mentioned radial nerve palsy splints. When the radial nerve function returns, it is again important for us to know and understand the order of motoric return for the radial nerve, especially in the case of radial nerve palsy. As we wait for these muscles to regain function, we should aim to preserve passive range of motion of the entire upper extremity. Once capable, strengthening can be in the form of gravity-eliminated positions, progressing to against gravity and finally against resistance. For the patient with radial tunnel syndrome, one should be careful to avoid excessive wrist extension and supination, which may reproduce the very pain that you're trying to avoid. Last but not least, I cannot stress the importance of evaluating and treating the patient with their context in mind. As Dr. Tugman said, repetition can exacerbate a patient's symptoms, and so we should really ask, how is the patient spending the majority of time in their day? Are they studying for long hours for an exam with their elbow propped up or bent? Do they have a habit of propping their left arm on the car window while they drive? Are they working from home with a less than ideal workstation setup? These are all stories that I've heard from patients who have come in with some form of compressive neuropathy, and I'm sure that you've heard of similar stories as well. So in addition to a clinical assessment, we as hand therapists don our detective hats and take deep dives into the patient's history to evaluate their environments. We then recommend methods for activity modification to best set the patient up for success. Even if not directly causative, their environment is very likely to be correlative to their diagnosis. We would be doing the patient a disservice if we treat without fully understanding their context and not evaluating them from a holistic lens. Thanks for tuning in.